Hi, I'm Dr. Gil Melmed at Cedars-Sinai Medical Center in Los Angeles, and it's my pleasure to be serving as a mentor for Dr. Philip Gu's presentation on visceral adiposity and its relationship to treatment response and subsequent risk of surgery in patients with IBD who are being treated with anti-TNF therapy. We've known for a very long time, ever since people have been doing surgery for Crohn's disease, that fat inside the abdomen or visceral adiposity is associated with Crohn's disease. This concept of creeping fat, for example, around severe ileal disease, particularly at the time of surgery, has been a well-described phenomenon. However, we don't really know, even today, what it truly means. What does it mean to have visceral adiposity? And is that reflective somehow in how we typically think of measurement of fat or obesity or body mass index? Which often is used as a metric for understanding pharmacokinetics and how the volume of distribution of drug may be affected by somebody's weight or somebody's adiposity. And in fact, visceral adiposity is different than BMI and is measured in a different way. Visceral adiposity, like in this study, for example, is measured using what can be described on CT scans, on cross-sectional imaging, as a much more precise understanding of what's actually happening inside the abdomen. And so what Dr. Gu and colleagues set out to understand was, does this concept of visceral adiposity, again, something that is a known phenomenon in Crohn's disease, does that associate with outcomes? Does it associate with treatment response? And does it associate with other outcomes such as surgery? And they did a retrospective look going back 10 years and identified patients with CT scans that they could measure this visceral adiposity. And what they found was that the visceral adiposity was in fact associated with anti-TNF response in a non-dose dependent manner, but also strikingly was strongly associated with the likelihood of progressing to surgery. What does this mean? Well, I think what we can learn from here is that there is a very significant relationship between visceral adiposity and poorer outcomes. The question is, how can we leverage that to better understand the relationship? And how can we leverage that to better improve our patients' outcomes? Perhaps patients with high visceral adiposity at the beginning or the outset of treatment should be counseled differently because of that poor prognostic factor. Perhaps these are patients, if not likely to respond in a high likelihood of going to surgery, maybe they should go to surgery before attempting a treatment that may be unlikely to be effective for them. So further work is certainly needed, but this article really spawns many ideas as to what is the relationship between visceral adiposity and clinical outcomes in a way that really opens the door for many more research questions to help understand the phenomenon better and how we can better use this and leverage this information to identify and improve patient outcomes.